Thank you very much for the kind invitation, Robin, and to you and to the other organizers for inviting me. Thanks also to all of you for getting up so early in the morning, and welcome to the very first talk of the 2018 SAGES CAGES meeting, or at least one of several concurrent first talks. Robin, I often give talks on mechanisms, but I'm afraid I have to disappoint you today. Those of you who are awake enough at this time of day to notice to pay attention, may notice that the title of my slide is not the same as what is in your program. What's in your program was a title that was assigned to me, and it was something about what are the mechanisms that explain why certain types of revisional surgery, or it's probably better termed conversional surgery if you change it from one thing to another, work well or not so well in individual people. And to be honest, I just have never done any research in that space, so I would not have any data to bring to the table on that question. Moreover, I'm not aware of any real solid data that explains mechanistically why a particular conversional operation does or doesn't work after another primary operation. And even more broadly speaking, the entire data set in the field of revisional and conversional bariatric and metabolic surgery is, at the present time, I would say inchoate. It's just starting to form, at least in terms of long-term data. And sitting in the front row is Kelvin Higa. I had the privilege of listening to a very scholarly presentation he gave about 2 weeks ago in Tokyo, where he convincingly laid out an argument that says that at present time, conversional operations probably should be reserved for clinical trials only and not done in regular clinical practice because the long-term data for efficacy is just not there yet. That's a pretty bold statement. I'm not going to try to defend or refute that, but it is the case that we do not understand why one particular revisional operation would or would not work at this present time. So what I'm going to talk about is something else, and that is a method at the present time to try as best we can to prevent the need for conversional bariatric and metabolic surgery. I disclose that I'm a principal investigator on the COSMID trial, which is funded by Johnson & Johnson, and the ARMS trial, which was previously funded by J&J and Covidien, although it's now fully funded by the NIH. The background of this talk is as follows. I'm going to be focusing on sleeve gastrectomy. And as you well know, laparoscopic sleeve gastrectomy is the largest, fastest growing, commonly used bariatric and metabolic operation in the world. In many countries, it has now outstripped all other operations as the most commonly used one. And generally, the results are good, which presumably is why it's so popular, as well as it being relatively simple surgically. However, in some patients, long-term weight regain or inadequate weight loss in the first place remain a problem. And that leads to the desire to, in some cases, convert a sleeve to something else, to a gastric bypass, for example, or a one anastomosis gastric bypass, or whatever your choice is. And I get the sense just from talking to a lot of people in the field that there's this still sort of underspring of uncertainty in the field about how are we going to do with really long-term data with this very, very commonly performed operation. Admittedly, I think the field is still smarting from the sting of lap banding, which soared to popularity, became the most commonly used operation in the world, and then suddenly crashed when long-term data showed it to be not very effective. I don't think that sleeve gastrectomy is going to go there because we're already far enough into its history that we would have seen worse data by now in the medium-term data. But there's still this kind of little worry of what's going to go on with really long-term data in sleeve gastrectomy. And regardless of what happens in the long term with that operation, it is now the case that some patients will regain weight and be prompted to undergo revisional operations. So how could we prevent that? Well, a very common hypothesis about the reason for long-term weight regain in some people with sleeve gastrectomy is that the remnant sleeve can dilatate out and balloon in out and become a large thing. To be honest, we do not have definitive data that that's the mechanism for weight regain in some people, but it's a very plausible hypothesis. If your main anatomic change is to make the stomach very small and a little narrow, tight sleeve, and then that balloons out and becomes floppy again, it's reasonable to think that may be a reason for weight regain. How could we prevent that? Well, a very simple idea would be to put at the time of surgery a non-adjustable restrictive ring or sleeve around the remnant sleeve, as is done in this picture of a banded gastric bypass. So I'm going to talk about a banded sleeve gastrectomy. Fairly new topic, I couldn't even find a picture of one, so I have to show you a banded gastric bypass. But the principle is the same. And what I'd like to show you today are results that will begin to answer the question of what are the long-term benefits and risks of a banded versus non-banded sleeve gastrectomy. I'll be showing you new data from a 5-year study It is by far the largest and longest-term study of banded versus non-banded sleeve gastrectomy in the literature. The number of patients in it is about as many as has been published in all similar comparative trials in the literature combined. And the follow-up is the longest yet done. So this is a collaborative project I'm involved in with Mohit Bhandari. And in it, we very simply looked at 220 obese adults who had underwent either a sleeve gastrectomy or a banded sleeve gastrectomy within the same calendar year at the same institution. 21% of them happened to have diabetes. And of them, within that calendar year, 152 underwent a standard sleeve gastrectomy without a band, and the other 68 had a banded sleeve gastrectomy. Otherwise, the operations were identical, except for this rather loose-fitting, non-adjustable band, or some would call it a ring, placed at the time of surgery. And then these patients were prospectively followed in a IRB-approved protocol at 0, 0.5, 1, 2, 3, 4, and 5 years with in-person visits to acquire data. At baseline, the two groups were very well matched for everything we measured in the categories of demographics, anthropometrics and body composition, glycemia, lipids, and blood pressure measures. Now, you'll note that there's 68 people in the banded group and 152 in the non-banded group, and I'll get into the reason for the non-similar numbers in the slide to come. So I'd like to now show you our main data from this study. Up front, at the operative time, it was a little bit more to put the band. No surprise. It takes a few extra minutes to put that thing in, but the overall operative time in the cohorts was 49 minutes versus 46 minutes, which I'm not a surgeon, but that seems pretty clinically insignificant to me. Not surprisingly, also, the operative blood loss was a little bit more in the banded sleeve gastrectomy versus the non-banded version. There are some perigastric arteries that need to be dissected, and they cause a little extra bleeding. But again, clinically insignificant differences of 44 versus 33 milliliters of blood loss at the time of surgery in the two operations. Neither of those is clinically important, I don't think. There was only one major operative complication in the short term, one in each group. Each group had one operative hemorrhage bad enough to require a transfusion, and that was it for short-term serious complications. This is my most important slide. The change in in percent BMI over 5 years. So first of all, both of them were very good at the beginning. They caused significant weight loss down to about 30% of total body weight, and totally identical at 6 months and 12 months. Thereafter, however, we began to see a difference. And at 2 years, there was a significantly greater weight loss in the banded versus the non-banded group, and that difference expanded at 3 years and 4 years and 5 years, with progressively greater and greater differences between the groups over time from 2 years through 5 years, with the final total body weight percentage loss being in the banded group about 33% versus only 21% in the non-banded sleeve gastrectomy group. That was percent weight loss. I'm going to show you now total kilograms weight loss. You get a very similar picture. For 6 months and 12 months, the two are identical, and then you begin to see an ever-increasingly large difference with the banded version causing greater total body weight loss over 2 through 5 years. Now, I am not a fan of excess body weight loss as a metric. I think it's very confounded by the incoming BMI, but it is well entrenched in your literature, so for the sake of surgeons, I'm going to show it to you. It gives you very similar results. The excess weight loss is the same in the two groups at 6 months and 12 months, and then becomes progressively greater over time in the banded compared with the non-banded group from 2 through 5 years inclusive. So the banded group has an excess weight loss that ranges from 83% to 90% over 2 through 5 years. In contrast, the non-banded group peaks at 73% excess weight loss at 1 year and then just falls steadily down to about 52% excess weight loss. If you define inadequate weight loss, which would be commonly used as a reason for conversional surgery as less than 50% excess weight loss, as I understand it, that's a common metric, that was seen in 0% of the people with the banded sleeve gastrectomy, compared with 43% of the people in the non-banded group. So that's a very, if you're talking about ways to prevent revisions or conversions, doing it in 0% of one group versus 43% of the other group is a very large difference at the 5-year time point here. The hemoglobin A1C values were a little mystical to me, but remember, this is not a diabetes study, so we just happen to have some people with diabetes, only about a fifth, and 4/5 did not have it. And there may seem like a big difference in A1Cs there, but note that they're all good glycemic control. So they started in the banded group at about 6.7, which is perfectly great glycemic control, and just stayed there throughout the study. And in the other group, they started at 6.6 and dropped from good glycemic control to even better glycemic control at about 5.6. I don't know the reason for that. The difference between the two groups is statistically significant, and it's backwards from what you'd expect from the weight loss. My only speculation is that by chance the regular non-banded group happened to have greater, more aggressive diabetes medication usage in the minority of people with diabetes. And other metrics of glycemic control did not match the impression you get from this slide. So for example, if we looked at diabetes remission, among the people who started with diabetes, it was the opposite. 83% remission at 5 years in the banded group compared to only 58% in the non-banded group. That was at 5 years, defined as an A1C below 6.5 off all diabetes meds. So for those with diabetes, the banded procedure was better at getting rid of their diabetes than the non-banded group. And then looking back at the whole group again, fasting plasma glucose went down beautifully in both groups with no difference between groups. In addition, there were no differences at any time point between groups in C-peptide levels. Lipids were a pretty consistent story. Cholesterol levels dropped progressively throughout the 5-year period in both groups and to an equal degree. LDL levels dropped progressively in both groups and to an equal degree. There was no statistically significant change over time in either group in HDL cholesterol, and then both groups enjoyed a very nice statistically significant progressive drop in triglycerides, also equal between groups, just like cholesterol and LDL. Here are some other results, little lesser ones. Hemoglobin, I'm not talking hemoglobin A1C, but hemoglobin, like hematocrit, was just a slightly higher in the banded group than the non-banded group by chance at the outset, and that remained the case at all time points. Now, it was very clinically insignificant difference, but statistically true. But the point is it was in the opposite direction from what you would predict if by chance the band were causing any sort of chronic bleeding with consequent anemia. There was evidence against that. By chance, again, serum protein levels were very slightly higher at baseline in the banded compared to the non-banded group. Really trivial difference, 6.9 versus 6.7. And neither intervention had any effect on that parameter, so the difference remained true at all time points after the baseline. And very similarly, there happened to be a slightly higher level of vitamin D3 in the banded compared to the non-banded group at baseline. Both groups raised that level nicely, but to an equal degree, so the difference between groups remained static from 0 through 5 years. There were no between group differences in blood pressure or anything else that we measured in my original table of many, many measures that we did at the baseline and all of the subsequent time points. What about safety and tolerability? Well, importantly, there were no known leaks, erosions, band slippages, major nutritional deficiencies, reoperations for complications, or deaths in either group. Now, a lot of people think in terms of what they know from the banded gastric bypass literature. And I think a common perception is, yeah, if you band a gastric bypass, I'm talking about sleeve gastrectomies in this talk, but if you band a gastric bypass, you may promote greater long-term weight loss, but at the cost of messed up lifestyle. So people will have intolerances to certain foods, they may have nausea problems, they may have reflux symptoms. So we asked the question whether that's true here. And we did and are continuing to try to finish a tolerability survey done by telephone with everybody who underwent a ban in this group and then was followed for at least 5 years. We're at a 75% response rate to date. I should have mentioned that the follow-up rate in the group was 83%, so we've got another 10 or so percent of the people to get to. And to date, of those individuals, only 6 people reported any troubles with some selected foods. And to my read of the actual handwritten stuff, it was very minor. Like one person has some trouble eating chapati quickly. One person has trouble eating rice as quickly as she used to. There were no consistent themes of any one particular food group that was worse than another, and it was only a half a dozen people that said anything. Nobody complained with major problems of nausea and vomiting. And this is maybe the most important thing. 100% of respondents to date have reported that they're satisfied overall with their operation out to at least 5 years. In the future, we're going to be doing endoscopies on all these people to try to get to the question of whether there's any increased evidence of GERD in the band compared to the non-band. We did a modified intention to treat analysis, or I did, because my job was to deal with the data in this thing. So there were no reoperations in the banded sleeve gastrectomy group for any reason. However, in the regular sleeve gastrectomy group, 19 out of the 152 people underwent conversional surgery during the course of this study for primarily inadequate weight loss, usually at about 3 years, or weight regain. So these were mostly converted from regular sleeve gastrectomies to a gastric bypass, or a banded gastric bypass, or a one anastomosis gastric bypass. And for the purpose of being rigorous, I included the data from these people in the regular sleeve gastrectomy group in a modified intention to treat kind of spirit. So these guys, in general, would have been expected to have, these 19 people, more weight loss after they had a conversional surgery to something stronger. I mean, most people, I think, would agree that those 3 other operations are a bigger hammer than sleeve gastrectomy. So to the extent that their data might have promoted more weight loss in the sleeve gastrectomy group than in the banded sleeve gastrectomy, this is a conservative bias against the main finding that despite these individuals, we still saw more weight loss in the banded group. I was going to mention earlier why I chose to study. There were 68 people back 6 years ago who underwent banded sleeve gastrectomy, and why didn't I compare them to 68 matched people who had a sleeve gastrectomy among the 152 that year who had the regular sleeve gastrectomy? And the reason was the 2 groups, with everybody included, happened to be beautifully matched on 28 different parameters, everything we measured. And I felt that since they were matched already, we should just use the larger numbers and avoid any potential bias from cherry picking from among the 152, a matched number of 68 to match the banded group. I'm going to give you my most important slide again as the take-home message, and that is that for the first 6 and 12 months after banded versus non-banded sleeve gastrectomy, we see identical weight loss. However, we then see greater weight loss at 2 years in the banded group, greater even more at 3, a greater difference from that at 4, and a still greater difference at 5 years after the banded versus the non-banded sleeve gastrectomy, with the impression that the trajectories are continuing to depart from one another out to 5 years, although we don't have data beyond that. I think a very important point to make here is that this band was very loose-fitting. It was a 7.5 size band. If you look at other uses of non-adjustable bands in, say, gastric bypass, other investigators will look at size 6 or 5 or even 4, which are getting to be really tight bands. And it's our bias in this regard that you don't need that. That the important mechanism of action is not to create a narrow choke point that food has to squash and squeeze through, and which would then cause troubles, nausea, vomiting, GERD symptoms, food intolerances, and much more likely erosions. All you have to do is place this thing loose and floppy around the outside of the sleeve, bigger than the sleeve is in the first place. I'm now going to be speculating about mechanism, so that every time a person eats and the stomach begins to expand a little bit, it runs into this band, which we think tickles afferent vagal fibers on the outside of the stomach to enhance satiation signaling and make the stomach feel it's more full than it is. And that's all you need to do. And by using a loose-fitting band, you get away with much fewer complications, or none, with much better weight loss over a 5-year period. The important contributors to this, so my role in this project is to have compiled, organized, analyzed, and interpreted the data, which is an enormous data set. I've written the paper and submitted it. It's now under review. And then, of course, I'm not a surgeon, so the most important other contributor is Mohit Bhandari, who did all these operations. And then other important participants are Winnie Mathur, Susmit Costa, and Arun Mistra. And that's all I have to say, and I thank you all for your kind attention.